Assalamu alaikum, everybody. Good morning, and depending on your time zone, good afternoon and good evening. Welcome to our session on nuclear medicine and molecular imaging at the Shaukat Khanum Cancer Symposium. We are excited. We will be joined by four internationally acclaimed speakers, and we look forward to a very interesting and exciting session, which will span about 2 hours. Our first speaker is Dr. Professor Nana Sigran. He will talk about neuroendocrine tumors. I would like to welcome him. He is professor at Royal Free Hospital in London. Dr. Gopi, please take over.
Hello, everybody. My name is Gopinath Nanasegran. I'm a consultant physician in nuclear medicine at the Royal Free London NHS Foundation Trust. And firstly, I would like to thank the organizing committee for giving me this opportunity to talk on radionuclide imaging and therapy in neuroendocrine tumors. For the next 30 minutes, I'll take you through the spectrum of radionuclide imaging and radionuclide therapy in neuroendocrine tumors in a systematic fashion. Firstly, neuroendocrine tumors are rare neoplasms which are characterized by overexpression of somatostatin receptors. And in general, conventional imaging is often challenging because of the small lesion size, low metabolic rate, and variable anatomical location of these tumors. And in fact, radionuclide imaging plays a very important role in management of neuroendocrine tumors, and it is shown to be superior in comparison to conventional imaging modalities for detection of metastatic lesions and also primary. Well, what are the common diagnostic challenges we come across in diagnosing neuroendocrine tumors? Is they often present late. It's a heterogeneous distribution, variable clinical presentation. There are various terminologies and classifications, and there are multiple treatment options available. Coming to neuroendocrine tumors, you can broadly classify them as foregut, midgut, and hindgut tumors. In foregut tumors, you come across tumors related to thymus, lung, esophagus, stomach, and duodenum. In midgut tumors, it is the tumors of appendix, cecum, ileum, and ascending colon. And hindgut tumors are the distal large bowel and rectum. And pancreatic neuroendocrine tumors presents as insulinoma, lipomas, glucagonomas, etc. And of course, based on the European Neuroendocrine Tumor Society, commonly called as ENETS, and the WHO, the tumors are graded into G1, G2, and G3. The grading systems are based on immunohistochemical staining of Ki67 protein, which is a marker of cellular proliferation. In G1 neuroendocrine tumors, the Ki67 is equal or less than 2%. In G2, it is 3 to 20%. And in G3 neuroendocrine tumors, the Ki67 is greater than 20%. And the G3 net can be further classified into G3A and G3B. G3A neuroendocrine tumors are well differentiated. G3B neuroendocrine carcinomas are poorly differentiated variety. And of course, management of these tumors is complex, and you need a large multidisciplinary team consistent of various specialties. The reason is you need to assess the histology of the tumor, disease status, both the clinical and radiological aspects, look at the radionuclide receptor status to plan the treatment, and then you have to decide whether the patient can go for surgical or medical options. And finally, we need to assess functional status of the patient. So all these require a group of physicians and the nursing team to decide which direction the patient move. Well, in terms of neuroendocrine tumor imaging, if you're going to assess the primary tumor, usually CT and MRI is used, followed by somatostatin receptor scintigraphy, which can be a SPECT as well as a PET tracer, which I'll come into these aspects in detail. Endoscopic ultrasound is also used, endoscopy and venous sampling. In terms of assessment of secondaries, somatostatin receptor scintigraphy is the most sensitive modality, followed by MRI. Well, coming to in terms of follow-up, especially when a primary has been resected, somatostatin receptor plays an important role in follow-up of these patients. Well, coming to radiological imaging in detail, what is the role of radionuclide imaging in patients with neuroendocrine tumors? It is useful to localize primary tumors and to detect sites of metastatic disease. It is useful for follow-up of patients, that is to detect residual, recurrent, or progressive disease, monitor effects of therapy, and also select patients for peptide receptor radionuclide therapy. And finally, it provides a prognostic parameter for response assessment of subsequent therapies. Well, what is the basic principle is patients with neuroendocrine tumors express somatostatin receptors. So the radio tracer is labeled with a somatostatin analog and it's injected into the patient, and these go and tag into the receptor sites, and you see them as the sites of abnormal focal increased tracer uptake. Well, the rationale for imaging neuroendocrine tumors is you can again classify them. G1 is a low-grade tumor, G2 is an intermediate type, and G3 is a high-grade tumors. And in fact, in G1 and G2, somatostatin receptor imaging is useful because it's a slow-growing tumor and well differentiated. Whereas the high-grade tumors, when the Chi67 index is greater than 20%, it's an aggressive tumor, poorly differentiated. Therefore, 18F-FDG is useful. Coming to radiotracers used in imaging neuroendocrine tumors, you can broadly classify them as SPECT tracers and PET tracers. SPECT tracers are Octreoscan, which is an indium labeled octreotide, and there are technetium labeled octreotide is also available. And in the past, we also used to image these patients with MIBG and pentavalent DMSA and deprotide. PET tracers commonly used is gallium-based somatostatin analogs like DOTA-TOC or DOTA-NOC or DOTA-TATE. 18F-DOPA is also used, 18F FDG for poorly differentiated neuroendocrine tumors, and occasionally copper dotatate is also used in recent times in some departments. Coming to somatostatin receptor imaging, it's been performed for several decades as an octreotide scan, and we used to perform them as a planar and localized SPECT, and more recently, more and more people are using SPECT CT. And often, initially we used to scan them at 4 and 24 hours, and later on we are moved into just the 24-hour imaging. And currently, most dedicated centers perform gallium-based dotatate imaging for assessment of neuroendocrine tumors. The reason is the gallium-based gallium DOTA PET-CT is of superior quality, low radiation dose, short half-life of 68 minutes, anatomical correlation is better. Imaging is approximately 60 minutes post-injection, and excellent target to background. Well, in terms of diagnostic sensitivity, if you're using an indium octreotide or a technetium-based octreotide, the sensitivity is around 89%. But if you're using a gallium dotatate PET-CT, the sensitivity is approximately about 82 to 100% because of better spatial resolution. Well, in terms of diagnostic performance of gallium-based tracers, generally you can classify them as gallium DOTA TOC, which has got a high affinity for somatostatin receptor 2 and lower affinity for type 5 and 3. The sensitivity and specificity is about 93% and 85% respectively. But for gallium dotatate, which has got 6 to 10-fold higher affinity for somatostatin receptor 2, and the sensitivity is about 96% and the specificity is 100%. Well, according to the S&M appropriateness criteria for somatostatin receptor PET-CT, there is a strong evidence to use gallium-based PET-CT in patients with well-differentiated neuroendocrine tumors. It identifies additional lesions and altered patient management in approximately about 20 to 70% of patients. And it also identifies unknown primary in about 60% of patients. And in fact, identifies functioning tumor sites in 2/3 of patients. Therefore, gallium dotatate is far better than conventional SPECT tracers. Coming to gallium DOTA physiological distribution is important, especially when you're reporting these scans. Highest physiological uptake or highest intensity is seen in spleen, adrenal glands, kidney, and pituitary. Moderately intense uptake is seen in liver, salivary glands, and thyroid gland. And finally, variable physiological uptake is seen in small and large bowel, and also gastric activity. Then coming to what are the common false positives. Often we see increased uptake within the uncinate process of the pancreas, which should not be over-reported as a pancreatic malignancy. We often see gallium dotatate uptake in infective and inflammatory process, degenerative bone disease, reactive lymph nodes, fractures, post-radiation therapy changes, planunculi, meningiomas, prostatitis, etc. So what are the common false negatives? Common false negatives are small-sized lesions and also poorly differentiated tumors. Coming to comparison between somatostatin receptor imaging, PET-based, SPECT-based, and CT. The sensitivity of PET-based somatostatin imaging is about 97%, specificity is 92%, and accuracy is approximately around 96%. But if you're using a SPECT-based tracer, the accuracy is around 58%, and if you're using CT only, the accuracy is only 63%. This is an example of a patient who's got dot-to-dot with mesenteric mass with multiple liver metastasis. And this is another example of a patient with unknown primary, and on gallium dot-to-dot imaging, you can see a focal area of increased tracer uptake within the small bowel, which is the primary tumor. Coming to the impact of somatostatin receptor imaging, PETCT, in the management of patients with neuroendocrine tumors, as you can see, by using somatostatin receptor PETCT imaging, there is a management change of approximately 20 to 70%. And often people ask this question, why gallium dot-to-dot scan? Gallium dot-to-dot scan is because of its high spatial resolution compared to somatostatin receptor SPECT imaging, and it's got a better tissue contrast compared to somatostatin receptor SPECT imaging. It's got a higher sensitivity for detection of G1 and G2 neuroendocrine tumors compared to the conventional FDG PET, and in fact superior to SPECT performed using indium labeled analogs. And finally, generator producing gallium dot-to-dot allows for in-house labeling. So what if gallium dot-to-dot is not available? Well, then indium or technetium labeled octretide SPECT-CT can be used to select patients for PRRT. And again, we have to remember why gallium is better than conventional SPECT tracers, because of improved sensitivity, secondary to resolution of PET, reduced radiation, higher affinity for somatostatin receptor 2, and the study duration is approximately about 2 to 3 hours in comparison to 24 hours in relation to SPECT-based tracers, especially indium. And whereas if you're using technetium, you can do it as a one-day protocol. Coming to the comparison of gallium dot-to-dot and FDG PET, FDG PET is useful in patients with high-grade neuroendocrine tumors, whereas gallium dot-to-dot is useful in low-grade and intermediate-grade neuroendocrine tumors. So what is the role of FDG PET-CT in a setting of PRRT? Is if a patient has got a high G2 where the Chi67 is greater than 10%, and you are looking for a discordant lesion. When you say discordant means the lesion is FDG positive and somatostatin receptor negative. G3 tumors, FDG PET is useful. And if you are seeing quick progression on a conventional imaging, ideally we should do a PET-CT scan to see if there is any differentiation. Lesions seen on CT and MRI but not seen on somatostatin receptor imaging, you have to do an FDG PET-CT scan. Finally, if you're looking for a second malignancy, FDG scan is useful. Overall, if you're using FDG PET-CT, the sensitivity in poorly differentiated neuroendocrine tumors is approximately about 90%, and the sensitivity in distant metastasis is about 91%. Well, coming to the summary of role of gallium dot-to-dot imaging in neuroendocrine tumors, it is useful in suspected thoracic and gastroenteropancreatic neuroendocrine tumors, and it's got a high sensitivity and specificity and should be the first line of diagnostic modality. Well, it is recommended for staging neuroendocrine tumors, recommended for suspected recurrence of neuroendocrine tumors, recommended for assessment of somatostatin receptor positive status before planning PRRT. It is superior to FDG in assessment of well-differentiated and moderately differentiated neuroendocrine tumors. And it identifies additional lesions and alters patient management in approximately about 20 to 70% of patients, which is quite high. And it identifies unknown primary in about 60% of patients. And finally, it identifies functioning tumor sites in about 2/3 of patients. So gallium dot-to-dot scan plays a very important role in the diagnosis of neuroendocrine tumors. Now let's move on to radionuclide therapy in neuroendocrine tumors. Well, what are the treatment options available for treating patients with neuroendocrine tumors? You have a surgical option. Patient can be treated with somatostatin analogs, interferons, and chemotherapy. There are several local regional therapies, molecular targeted therapies, and PRRT. And finally, supportive palliative care and pain control management. Well, What are the treatment options is, if the disease is restricted to the liver, surgical and loco-regional approaches should be considered. And chemotherapy is often kept for highly proliferating neuroendocrine tumors and pancreatic neuroendocrine tumors. Well, before going into peptide receptor radionuclide therapy, what is the role of somatostatin receptor imaging in this setting? Somatostatin receptor imaging has a central place in the diagnosis and follow-up of patients with neuroendocrine tumors. And also it plays a key role in identifying patients for peptide receptor radionuclide therapy. So what is peptide receptor radionuclide therapy? It is a molecularly targeted radiation therapy which involves administration of radionuclide peptide which targets high affinity and specific receptors which are overexpressed on the neuroendocrine tumors. Well, coming to the historical perspective, it's quite fascinating. In fact, in 1982, there was invention of the first somatostatin analog, octreotide. And in 1985, somatostatin receptors were discovered on the intestinal neuroendocrine tumor cells. In 1987, first use of iodine-based octreotide. And in 1990, development of indium pentatreotide, which is commonly called as an octreoscan. And in 1992, the first patient were treated with high activity of indium pentatreotide. And in 1997, development of yttrium-based DOTA octreotide. And in 1998, development of lutetium-based octreotide. And finally, in 2000, the first clinical use of lutetium dotatate for patients with metastatic neuroendocrine tumors. And in 2017, the NETA-1 study was published, which was a game changer. And in 2018, FDA approves lutetium dotatate for use in patients with neuroendocrine tumors. Then, what is the basis of receptor affinity? In fact, it depends on the radionuclide and the chelator and modifications to the peptide. All these factors have an impact on the affinity for different somatostatin receptor subtypes. In fact, the PRRT agents have the highest affinity for somatostatin receptor 2, which is most highly expressed subtype in gastroenteropancreatic neuroendocrine tumors. Coming to the mechanism of PRRT agents, how does it act? PRRT agents act via a Trojan horse mechanism to enter and destroy the neuroendocrine cells. Well, this is an example of neuroendocrine cells. And the radiotracer, which is a PRRT agent, which binds onto these somatostatin receptors on the neuroendocrine cell surface. And how do they destroy? Yes, they get internalized into the cell and emit beta radiation, which in turn induces double-stranded DNA breaks. It's a double-stranded DNA breaks leading to cell cycle arrest and apoptosis. And that is the mechanism how PRRT agents goes to destroy the cell. Coming to the pre-therapy assessment of patients, it is mandatory. It has to be histologically proven neuroendocrine tumor, and the tumor should express somatostatin receptors, whether it could be a SPECT-based tracer or a PET-based tracer. And in fact, in terms of patient selection, it should be neuroendocrine tumors originating from the gastroenteropancreatic tract. It should be well differentiated, that is G1, G2 histological grade, unresectable, metastatic disease, or in patients who are unfit for surgical resection, and patients who demonstrate adequate radiotracer uptake in somatostatin functional imaging, tumors that have progressed despite prior therapies. And then you may ask a question, what is the level of somatostatin receptor uptake for patients' PRRT eligibility or suitability? In fact, on the somatostatin receptor imaging, whether it could be a SPECT tracer or a PET tracer, again I'm stressing this, the tumor uptake of the radiotracer should be at least as high as normal liver uptake, which generally in terms of Krenning score greater than or equal to 2. So what are the absolute contraindications for peptide receptor radionuclide therapy? If patients are hypersensitive to Lutathera or any other of its excipients, if you have an established or a suspected pregnant patient, or when pregnancy has not been excluded, it's an absolute contraindication. And also renal failure with a creatinine clearance of less than 30 mL per minute is an absolute contraindication for radionuclide peptide therapy. What are the relative contraindications? As patients with severe heart failure, or if they had prior external beam radiotherapy, kidney failure with a creatinine clearance of less than 50, hemoglobin less than 8, platelets less than 75, leukocytes less than 2000, neutrophil count less than 1, and if your somatostatin receptor imaging shows negative or mixed lesions, that is Krenning score lesser than 2. And also in patients with hepatic impairment, where the total bilirubinemia is greater than 3 times the upper limit of normal. Coming to the treatment pathway, which is quite interesting, you have to have an adequate, safe facility and safe treating personnel, and the patient should be discussed in a multidisciplinary board meeting, and the suitability should be assessed there, and it should be treated in an approved facility, appropriate trained personnel, radiation safety equipment should be in place, and also procedures for waste management. Handling accidental and contamination of the site should be, you should have a standard SOP for that. Handling accidental contamination of the personnel, you should have a strict protocol for that. And finally, it should be administered by appropriately trained medical staff, nursing staff, with a medical physics team and technologists. And in fact, consent is very important, and the ENETS recommends that patients should sign a consent form, and you should explain to them about the adverse effects such as renal dysfunction, reversible hematological toxicity, myelodysplastic syndromes, or acute leukemia. Well, what is the suggested checking list you need to have before you decide to treat the patients? You need to have some baseline tests. The essential ones are patients should be reviewed at the multidisciplinary team, check appropriateness for PRRT, review the histology, review the imaging, assess the patient performance status. Imaging, patient should have a somatostatin receptor scan, at least preferably within the previous 6 months, and recent cross-sectional imaging at least within the 3 months before treatment. If the patient's got bone metastasis, spinal MRI, if there is significant spinal metastasis, or if there is a suspicion of spinal cord impingement. Blood test, you should have a hematological, liver, and renal function. Cardiac function test should be done in patients with suspected cardiac heart disease. And of course, checklist for patient performance is important. Desirable is you can have the baseline levels of tumor markers, FDG PETCT, especially in patients with higher grade tumors, to assess for any discordant lesions. Coming to what are the basic minimum laboratory tests needed before each infusion. In fact, you should have an hematological, which just includes hemoglobin, white cell count, and platelet count, kidney function with EGFR and creatinine clearance, liver function. At least these 3 parameters should be assessed before any treatment. And patients are infused with amino acids to protect the kidneys. In fact, renal radiation exposure is often reduced approximately about 50% by concomitant administration of amino acid infusion. And amino acid infusion should be infused at least over 4 hours, and they should be started at least 30 to 60 minutes before initiation of PRRT. And in fact, the model is patients get 4 cycles at an interval of 8 weeks, and the injected activity is around 7.4 gigabecquerels per treatment, and you should have a thorough blood test before planning each treatment. And the blood test includes renal and liver function tests. And in terms of administration procedure of antiemetic and amino acid solution Lutathera, patients are given antiemetics at least 30 minutes prior to amino acid solution. Amino acid solution is approximately 1 liter, and it is infused over 4 hours. And the main treatment, Lutathera, is an infusion rate up to 400. The duration of the whole treatment is approximately about 30 plus or minus 10 minutes. Method of administration, the recommended infusion method for administration is the gravity method, or you can use any other methods deemed appropriate and safe, including the use of infusion pumps. Common side effects or drug reactions include thrombocytopenia, anemia, neutropenia, renal toxicity, and hepatotoxicity. And management of severe or intolerable adverse reactions includes required temporary dose interruption, extending dosing interval from 8 weeks up to 16 weeks. And if it extends beyond 16 weeks, it is discontinuation of Lutathera is suggested. And in some conditions, there'll be dose reduction. Coming to radiation protection, for the first 7 days, keep at least 1 meter away from other people, limiting contact with children and pregnant women up to a maximum of 15 minutes per day. For first 7 days, patients should sleep in a separate bedroom from your partner. First 15 days, patients should sleep in a separate bedroom from children and pregnant partners. And patients should use contraception to avoid becoming pregnant or fathering a child up to 6 months post-treatment. Finally, follow-up for patients between the cycle. You need to do complete blood counts every 2 to 4 weeks. Frequency can be adopted depending on the clinical scenario. Renal and liver function tests should be available before every treatment. Immediate and long-term is complete blood cell, renal function, and liver function tests should be performed every 4 weeks for at least first 3 months, 8 to 12 weeks for the first 12 months, and thereafter twice a year if clinically indicated. CT, MRI, depending on the disease status, and combined functional morphological imaging often helps, and it helps in better reflection of the true tumor behavior. And finally, what is the current evidence and why is this treatment so well? Based on the NETA-1 trial, it is an international multicentric randomized trial where 41 centers participated across 8 countries. And they had 2 arms, 229 patients, and one group received Lutathera, which is PRRT, and the other group received octreotide injection. And the results were excellent. In fact, the median progression-free survival was around 28 months for patients treated with PRRT in compared to 8.5 months for people in control group. So in conclusion, radionuclide therapy and imaging plays an important role in management of neuroendocrine tumors. PRRT is a well-established treatment option in patients with metastatic, unresectable, progressive, somatostatin receptor positive gastroenteropancreatic neuroendocrine tumors. MDT patient selection and management is vital and it's mandatory. Lutetium dotatate is often associated with substantial survival benefit in patients with gastroenteropancreatic neuroendocrine tumors. I hope you enjoyed this lecture. Thank you once again for giving me this opportunity to share my thoughts and experiences, and have a great Congress. Thank you very much.
Thank you very much, Professor Nanasegran, for this wonderful review of neuroendocrine tumors, their application, the application of PRRT. We look forward to having a discussion after all the sessions. So we'll, please feel free to keep adding your questions and we'll take them all together at the end. Next, we have Dr. Simi Dadparwar. She is a professor of radiology at Temple University, fellow American College of Nuclear Medicine and fellow American College of Radiology. She will speak to us about PET-CT in breast cancer management and an update on current literature. Thank you very much. Please go ahead, Dr. Simi.
Good morning. My name is Dr. Simin Dadparwar. I'm professor of radiology in the Division of Nuclear Medicine and Molecular Imaging at Temple University Hospital. I am grateful to the Society of Nuclear Medicine in Pakistan for inviting me to give a talk on the PET-CT in the breast cancer management and update. The role of molecular imaging in breast cancer has started from bone scan, and then FDG PET came in, and then now we have the 18 FES, which is the fluorodestradiol, and then also sodium fluoride, which was another bone-seeking agent. And later on, HER2/neu and probably EGFR is going to come into play for measurement of the response to therapy. I have no conflict of interest. This, I'm giving you some examples. This is a 42-year-old lady with mild back pain. Whole body bone scan was questionable, abnormality in the sacrum. And then when the bone scan was done, this was the only finding in the sacrum. The PET-CT scan was ordered, and PET-CT showed that the patient has a lytic lesion in the sacrum with a high FDG uptake in the same area, which was consistent with metastatic bone disease. This was another patient that was reported as normal. The bone scan was reported as normal and was a questionable area in the mid-thoracic spine. The same patient, when she went for having the PET-FDG showed that she had sclerotic bone lesion in the mid-thoracic spine. This is the same patient after 6 months had multiple osteoblastic metastases in the entire skeleton. So we can have all different varieties of the bone scan, from something which is like monostotic bone lesion versus multiple bone metastases, osteoblastic, in the entire skeleton. Role of molecular imaging in breast cancer is that precision medicine is the goal of the current cancer therapy. Disease characterization, phenotyping, prediction of the response to targeted therapy. Molecular imaging helps in better understanding of the fundamental molecular pathways in vivo non-invasively. PET as a molecular imaging modality has an important role in development of novel probes targeting important biological and biochemical process. This is a 43-year-old female with pre-PET-CT imaging as stage 2B invasive ductal carcinoma and previously unsuspected distant metastasis. And this is from the European Journal of Nuclear Medicine from Dr. Gary Ulliner that shows that the PET-CT for the systemic staging newly diagnosed triple negative breast cancer showed that the patient, even though the pre-PET-CT was stage 2B, turned out to be stage 4 malignancy. Importance of estrogen receptors is that systemic therapy of breast cancer is primarily based on steroid hormone receptors, estrogen and/or progesterone. Endocrine therapy is good for the hormone-sensitive tumors, and chemotherapy is good for the hormone-insensitive tumors or hormone-resistant tumors. Estrogen receptor is the predictive factor, important determination of response to endocrine therapy, and prognostic factor affecting disease-free survival and overall survival of the patient. This is the cell that estrogen signaling classical pathway that it is in the nucleus, and it is showing the estrogen, and it's showing the estrogen receptor complex, and also is showing the estrogen response elements, that each one of these are being used for the, for the therapy of these patients that they are estrogen receptor positive, that how to stop that for stopping the growth of the tumor. Predictive prognostic biomarkers, about 70% of breast cancers are hormone sensitive, express ER or PR, and they are candidates for endocrine therapy. One of the key factors in improving breast cancer mortality. Hormone sensitive have better outcome and prognosis than hormone insensitive tumors. And endocrine therapy is the preferred first-line treatment and is most effective in hormone-sensitive breast cancer patients. Response rate is only 50 to 75% on these patients. Beyond first line of therapy, response decreases to 25% due to various resistance mechanisms. Recently, a new imaging agent by name of Seriana, or which is the fluoroestradiol F18, is made to see that if we can see the PET-CT imaging for the detection of estrogen and also positive lesions as an adjunct to a biopsy in patients with recurrent or metastatic breast cancer. What happens after a while of therapy of the patients with for the breast cancer, they may lose their estrogen receptors. So Seriana contains fluoroestradiol fluorine, a synthetic estrogen analog. Chemically, fluoroestradiol is F18, 16 alpha, fluoro 3, 17B, diol estrine, that 135. So it is a very long formula. Limitation of use is that tissue biopsy should be used to confirm recurrence of the breast cancer and to verify ER status by pathology. Seriana is not useful for imaging other receptors such as human epidermal growth factors and also HER2/neu and progesterone receptors. Molecular heterogeneity of metastatic and recurrent disease and overall discordance rate between the primary and metastatic disease are as high as estrogen receptor 20%, progesterone receptor 33%, and HER2/neu 8%. Limitation of in vitro assays is that sample dependent and is invasive, and its repeated measurement is not feasible, is poor predictor of response, and interlaboratory variability and lack of uniformly accepted cutoff values for discriminating ER positive from ER negative tumors. Clinical need for this is that a tool is needed to identify patients with hormone-sensitive breast cancer assessed by in vitro assays who do not respond to endocrine therapy. So this is the tumor FES uptake versus ER levels that shows that there is a good relationship correlation between the tumor uptake and also the receptor concentration of these patients. So good correlation between FES uptake and in vitro assay of the ER, which is reliable in vivo assessment of the ER status in breast cancer. This is another one that you can see the SUV of these patients, and overall agreement between the ER assay and FES uptake is very good. This is quantitative conventional ligand binding assay, and this was the quantitative conventional ligand binding assay or immunohistochemically staining, that this was done in 1988. As early as 1988, this study was done. Correlation of FES and in vitro, estrogen receptor is that in 11 studies that was performed with 327 patients, the sensitivity was 78%, but the specificity was 98%. So the negative predictive value is extremely helpful. Its high specificity supports the ability of the FES PET to detect loss of ER receptor expression and the function. And that is when they switch from the endocrine therapy to the chemotherapy. FES tumor uptake and prediction of response to endocrine therapy is that when you look at this, the tamoxifen and ER modulator binds to the ER and blocks interaction of the ER estrogen. And this is the site that tamoxifen helps. And then Faslodex, as a selective ER degrader, blocks the action of the estrogen, that this is the place that Faslodex works. And aromatase inhibitors reduces estrogen by interfering with its production. Aromatase inhibitors are given to the patients postmenopausal, and also tamoxifen and Faslodex is given to the patients in premenopausal breast cancer patients. CDK4 and 6 inhibitors mainly block retinoblastoma tumor suppressors protein phosphorylation, preventing progression through the cell cycle. And then everolimus, that it is these are the inhibitors that they are being used in some of the patients. So tamoxifen blocks the estrogen, the estrogen interaction. And when you're looking at the pre-tamoxifen, you can see that the patients who is responder, the SUV was 5.7. Post-tamoxifen use, the SUV on the FDG PET came down to 3.1. In this patient who is non-responder, the SUV was 0.93, very low, and post-therapy, the SUV did not change much. So that is the baseline FES SUV, that on the responders, they are doing really good, and negative predictive value is very good, and on the non-responders, they are very low. Quantitative FES PET predicts response to endocrine treatment, and the tamoxifen and AIs and Faslodex in breast cancer. So it has been shown that the patients that they are responders pre-therapy, this is the patient, this is the FES imaging on this patient, this is the FDG imaging on this patient. You can see that FDG shows that after 3 months, the patient has responded. In the non-responders, FES was negative and FDG was positive, and then 6 months later, FDG became more positive. So that is very important. It has been shown that none of the patients with the FES SUV of less than 1.5 have responded to therapy. FES tumor uptake is influenced by the site of metastasis. For example, in the 91 patients that they had metastatic, like about 1,617 metastatic sites, the percent bone was 78%, lymph nodes were 15%, lungs were 4%, and liver was 2%. It is difficult to identify. Liver metastasis was identified by CT on 11.2%, but PET identified on 56.6%, or both of them combined 32.2%. So it is very important to see on those patients that they are not responding, where are the tumors and how we can help out those patients. It is difficult to evaluate liver metastasis because of the high background. As you can see, FES goes to the liver. Median tumor uptake varied between patients. SUV max was 0.54 to 14.2. So FES uptake in bone metastasis was more than lymph node and lung metastasis respectively. This is the presented in the Journal of Nuclear Medicine in 2018. Potential applications for the FES PET-CTs that does not replace the biopsy for diagnosis, to be used as an adjunct to biopsy to detect the ER availability in recurrent and metastatic breast cancer, and also can help direct endocrine therapy. It has high negative predictive value, excludes patients not going to benefit from endocrine therapy, and the advantage is that it is non-invasive, and it is, it is not sample dependent, and because what happens is that it would address the heterogeneity and evaluates multiple lesions non-accessible at the same time, addresses discordance and detects resistance during therapy, and it is invasive. It is very good for invasive ductal and lobular breast cancer, especially for the invasive lobular breast cancer, that it is not good, it's not showing high FDG uptake. Limitations is that it is not optimal for evaluating patients with only hepatic metastasis. CT with contrast or MRI would be much better choice. Washout of minimum 60 days if blocking agents such as Faslodex or tamoxifen are used. This is a patient with F18 fluoroestradiol, and diagnosis of the patient is the patient has these are all the estrogen receptor metastatic site, binds to the ER and allows for visualization and quantitation of ER status via PET imaging. And this is the FES in the patients with is not FDG. This is the perfect example in the ER positive disease that FES is positive, and so is FDG on these patients. So you can see that this patient would be able to respond to endocrine therapy. This is the patient who is ER negative while FDG glucose metabolism is positive, and this patient is not a good candidate for the therapy with endocrine. The problem is the drug interaction with Cerianna and systemic endocrine therapies, ER modulators and ER downregulators that they may reduce detection of the ER positive lesions after administration of FES. For example, the estimated time period over which ER binding may reduce FES binding following administration of the ER targeted systemic endocrine therapy is that for the ER modulators such as tamoxifen and toremifene, 8 weeks we have to wait, and for ER downregulators we have to wait for 28 weeks because it may falsely bring the Ceriannas or the F18 fluorodestrals uptake lower. It helps in treatment selection. So this is the patient that the patient has been treated with aromatase inhibitors, and this is the first patient that pathologically the patient has uptake on the FDG scan on the right axillary lymph nodes and on the bones, and on the FES lesions are in the axial skeleton and axillary lymph nodes, and 8 weeks after is post-therapy that near complete metabolic response you can see. This is a patient who is non-responder. The first patient has been on treatment for more than 70 weeks, the patient number 2. Pathologically, the patient FDG shows multiple areas, but when you look at the FES uptake, only very few, and this patient did not have any metabolic response, and you can see that FDG uptake got much worse after the therapy. FES is very important in the low metabolically breast cancer, lobular breast cancer, diffuse growth into stroma with fewer calcification, and therefore generally more difficult to detect than ductal type. Metastatic disease is also difficult to detect with conventional imaging, and it has abundant ER expression, and therefore ER imaging with fluoroestradiol PET can help out to assess the extent of the disease in lobular breast cancer. FES fulfills the same purpose as F18-FDG in lobular breast cancer. This is a patient with a lobular breast cancer that is ER positive patient, and 18 FES better demonstrates extent of the disease than FDG. You can see that this is the Seriana on this patient, and this is the FDG on this patient. That is the huge difference. So lobular breast cancer, ER positive, locally disease treated and controlled. Recurrence 8 years later with metastatic vertebral fractures, F18-FES demonstrates lesions not visible on the FDG PET, and all lesions still express ER positive. They are treated with the aromatase inhibitor stable disease after 2 years following having the Serianas or the F18 estradiol's scan. This is a patient with the, with the FES positive, FDG positive, and this patient is going to respond. This is a patient with FES negative, but FDG positive, and this patient is not going to respond. So this is again, with the permission, it is reprinted that, shows what is the advantage of having FES in these patients, especially when they are coming up, ER positive patients, when they are coming up with the multiple metastatic disease, and you want to know that if this metastatic disease is still ER positive, should you continue the endocrine therapy or should you switch to chemotherapy? This is a patient with F18 fluoride for the bone scan, and this is the FDG PET on the patient that does not show that much of uptake, and this is the patient that has been treated with the F18 FDG, has been treated for the with the hormonal therapy and has partially responded. This is a patient with the HER2 metastasis, HER2 positive. The HER2 positive patients, unfortunately, they have the tendency to have the brain metastasis since the chemotherapy and hormonal therapies do not go through the blood-brain barrier. This is a patient with the identification of HER2 positive on these patients and HER2 negative. This is a patient with a 66-year-old lady with HER2 negative, primarily breast cancer, and but has HER2 positive metastasis. Targeted PET-CT demonstrated a substantial partial response. This is the hope that is going to be the next thing approved for the breast cancer management of the patients. So these are the HER2 negative patients that they may have HER2 positive metastatic disease. So critical role of the tumor heterogeneity in summary is that estrogen receptor status changes in many patients as the disease progresses, resulting in some or all tumors having no estrogen receptor. ER receptor expression is lost to some degree in 8 to 50% of the patients. In patients with mixed ER status heterogeneity or no ER expression, ER negative hormone therapy is ineffective. This is a patient with the ER positive, another case that I would like to share with you, ER positive that was positive on the FDG PET, and you see that Seriana shows more extensive uptake in this patient, and post-therapy with endocrine, the patient has responded. This is a patient who is ER negative, and you can see that PET-FDG shows multiple areas of uptake, and only on the Seriana, few uptakes in here, and post-therapy, there was no response, and the patient got worse. So it has been shown with the patient surviving without progression, that if these patients, they are the FES positive patients, the FES positive patients are, zero positive, 0% FES positive, these patients die very fast. The patients that they are FES 1 to 99%, that they are positive, they live for much longer time. And the patients that they have 100% FES positivity, they live a long life and they can respond to therapy. I want again to thank the Society of Nuclear Medicine in Pakistan for inviting me. We are looking forward for more collaborations between the American College of Nuclear Medicine and the PSNM. Thank you and have a great day.
Thank you very much, Dr. Daud-Parvar, for an excellent overview of PET-CT and the novel tracers that are around now for imaging breast cancer. We'll move on to PET-MRI now, since that is the hot topic these days. So PET-MRI and prostate cancer. We have Dr. Laura Evangelista. She is assistant professor at University of Padua in Italy. She is also editor-in-chief of Clinical and Translational Imaging and chair of E&M Task Force for Women Empowerment. She has authored more than 160 peer-reviewed articles, edited several chapters, books, and reviews for more than 20 journals. So over to you, Dr. Evangelista.
Good morning to everyone. It is a really pleasure to be here for talking about PET-MRI in prostate cancer, clinical experience and literature evidences. I will try to give you some information about how to perform PET-MRI in prostate cancer. In particular, we focalize my attention about the protocol information. I will try to understand when PET-MRI is useful in clinical practice by starting with the initial staging of disease, by talking about biochemical recurrence of prostate cancer, by using PET-MRI for radiotherapy planning or guide stereotactic body radiotherapy in patients with oligometastatic disease that nowadays represent a very hot topic in the field of prostate cancer. And I will give you some information about the comparison between PET-MRI versus PET-CT. And finally, I will just to explain and show some clinical cases and our clinical experience. Well, we can start with the first information about the protocol acquisition. We have just to remember that PET-MRI is characterized by a combined PET and MRI system in a single scanner. Therefore, when we talk about hybrid PET-MRI, we talk about of a single scanner and not the co-registration of the different PET and MRI image separately. Well, about this, we have to remember that PET-MRI has some strength, but also some weakness. The major strength of PET-MRI is it has less radiation dose from MRI, has a simultaneous multimodality imaging, it has an excellent soft tissue contrast. That, in my opinion, and also due to the clinical practice, it is probably the most important thing that is correlated with PET-MRI, but we have also at disposal the association of functional imaging PET-MRI and a plenty of agents for PET use, but we are also able to enable good visualization and quantification. It means that we have the opportunity to have a good imaging quality, but we have also the opportunity to make a quantification by using both PET, for example, by using semi-quantitative data, but we are also able to obtain, for example, information from the diffusion weighted imaging with the ADC values. Well, on the other side, we have also some weakness that are relative to PET MRI system. The first one is the high capital cost. It means that the cost of PET MRI due to the technique, but also due to the maintenance of the machine is very high as compared to PET-CT scanner. However, there is also a lack of protocol and standardization due to huge variation in MRI protocols, no combined reporting MRI and PET. In some institutes, we can see that the acquisition of the information by PET and MRI are separately taken by the different type of experience, and we have also limited the flexibility of a combined PET MRI system and an acquisition times of up to 60 minutes. It has a very long acquisition time. The protocol acquisition should be based early from the PET image. By using fluorocholin, we can perform the early or dynamic and late image. If we use a gallium PSMA or fluoride PSMA, we are used to make only late acquisition, and normally the time acquisition is about 3 minutes mainly for gallium PSMA in order to reduce the hallosaline. For the MRI sequences, we can decide to use for the prostatic bed the common T2 TADC, T1 post-contrast and diffusion weighted imaging sequences. For the lymph node, we need to use T1 post-contrast and also the diffusion weighted imaging. And for bone metastasis, again, we can use the diffusion weighted imaging T1 and T2 sequences. However, we have also to remember that MRI, as compared to PET-CT, has not the opportunity to use CT for making the attenuation correction. And for this reason, we have to use specific sequences for obtain a good quality of PET image. In these cases, we can use the exon sequences that normally is usually performed in some PET MRI acquisition protocol that is based on the pre-existing attenuation maps for body part. In our clinical practice, we are used to use Capirinia sequences that is very similar to Dixon, but we have some modification about soft tissue and bone. Well, after making an information about protocol data, we can now start about the initial staging of disease. Well, PET MRI surely can be used for the T staging. It means that now we are able to analyze the presence of the primary tumor by using PET MRI, because we can reinforce the information provided by PET with the MRI soft tissue contrast enhancement. Well, as you can see in this slide, gallium PSMA PET MRI is able to provide a good sensitivity for the evaluation of extracapsular extension as compared to the nomogram by the Memorial Sloan Kettering Cancer Center and Parting Table, and while on the other side, gallium PSMA has a lower sensitivity for the identification of seminal vesicle invasion as compared to the nomogram and the Parting tables. Therefore, PET MRI can be useful for the identification of dominant intraprostatic lesion and for the evaluation of extracapsular extension. About the end staging, as you can see again in this table, gallium PSMA has a sensitivity quite similar to the nomogram, while it demonstrated the dye specificity equal to 100% higher as compared to the nomogram and Parting table. Therefore, PET MRI can be used for the identification of a locoregional and distant lymph node, and it can be used for guiding to extended lymph node dissection more accurate than conventional nomogram. Therefore, by considering this table that was obtained by a recent published meta-analysis in the European Journal, we can see that the pooled sensitivity for the identification of a primary tumor was 95% with the PET MRI, and also we are able to obtain a intermediate pooled sensitivity for the identification of lymph node metastasis. Now we can move to another important chapter of the prostate cancer, the biochemical recurrence of prostate cancer. For the evaluation of recurrence in prostatic fossa, PET-MRI has the opportunity to have a high contrast resolution by using MRI that helps in detecting the recurrence in prostatic fossa after radical prostatectomy. However, similar detection rate was reported also in prostatic gland in case of a patient who was treated by using radiotherapy. In this case, we can plan a salvage radiotherapy in case of recurrence. About the lymph node disease, it has shown that a PSMA positive lymph node is more often detected also for lower PSA levels. And by using PET-MRI, we can increase significantly the identification of lymph node metastasis also in case of a very early PSA recurrence, and if the lymph node diameter less than 5 millimeters, that is normally the cutoff used for the MRI acquisition. In this slide is represented the detection rate by PET-MRI according to the PSA level. As you can see, also for very low PSA level, we have the opportunity to detect the presence of recurrence in 58% of the cases, but it can reach the 97% of detection rate in case of a PSA level higher than 1.5 nanogram per ml. And again, by considering the recent published data in literature, the pool detection rate in restaging for the PSMA PET-MRI is 82%, while with the choline PET-MRI it is 77%, is quite similar. However, the amount of data with the PSMA PET-MRI is significantly higher as compared to choline PET-MRI. Now we can move to another important topic, that is the use of PET-MRI for stereotactic body radiotherapy in patients with oligometastatic disease. In this recent paper that was published in Abdominal Radiology by our group, we demonstrated that for the identification of recurrence in patients with oligometastatic disease, PET-MRI has an important advantage, not only in case of patients with a PSA level less than 0.5 nanogram per ml, with a detection rate of 58% with the choline PET-MRI, quite similar to those reported with gallium PSMA, but it can reach 91% in case of a PSA higher than 0.25 nanogram per ml. And as you can see, probably the major place was reported by MRI mainly in case of a PSA level less than 0.25 nanogram per ml. And when we compare the similar data in case of the recurrence in prostatic fossa, we can see that 53% of detection rate was reported mainly by MRI, while similar data was reported also in case of a PSA level higher than 0.25. It means that probably MRI in this case plays an important role for the detection of recurrence in prostatic fossa. While in case of lymph node, as you can see, the major play was reported for the major player was in this case the PET component with a detection rate of 8% for the lymph node metastasis in case of a PSA level less than 0.5 nanogram per ml, and it can reach 30% in case of a PSI between 0.25 and 1 nanogram per ml. Whether the role of PET-MRI in oligometastatic prostate cancer is now represented an important role also as for the study design. This is an example study design by using PSMA, PET-MR or PETCT for guiding to stereotactic body radiotherapy or surgery, and again PSMA will be used for the evaluation of response to therapy. As you can see, PET-MRI for unveiling a molecular defined oligorecurrent prostate cancer state amenable for curative intent ablative therapy, and this is a study protocol for a phase 2 trial, and the principle of imaging with the therapeutic drive, assessing a novel imaging modality and molecular tracer to unveil a localized or prostate cancer amenable to curative intent ablative therapy. The most important thing is to understand when we can use PET-MRI and when we can use PET-CT. First of all, we have to make some difference between PET-CT and PET-MRI. The first difference about PET-CT and PET-MRI is the availability. PET-CT is wide available. The readers has a high experience and also high clinical practice, and it has a high sensitivity made with the digital scanner. However, the main disadvantages for PET-CT in prostate cancer is the low accuracy for the detection of local recurrence and also moderate accuracy for the detection of osteomedullary metastasis. These disadvantages are, on the contrary, the main advantages of a PET-MRI scanner, but we have also to remember that the PET-MRI scanner has also a high sensitivity like the new digital PET scanner. The main disadvantages of a PET-MRI are the low availability and low experience of the readers. Actually, we can count of not more than 120 scanners worldwide as compared to PET-CT that are enough worldwide. Well, when we compare the detection rate for radiolabel PSMA in colon PET-CT versus PET-MRI, we can see that the agreement between the two methods was high. MRI is a crucial component for the identification of a local recurrence. Similar data have been reported for the detection rate in recurrent lymph nodes, and in the skeletal metastasis, the detection rate is similar, although MRI is able to detect earlier the presence of osteomedullary lesion. However, PET-MRI demands a 79.7% lower exposure to radiation than PET-CT. Therefore, in case of serial FDG examination or fluorocolin examination, we can use PET-MRI as compared to PET-CT in order to reduce the dosimetric acquisition of patient, but we have the problem of a longer acquisition time for PET-MRI than PET-CT, about 2 times more. And when we compared again the data now available about the head-to-head comparison between PET-CT and PET-MRI, we can see that the full detection rate for prostate cancer was quite similar with PET-CT and PET-MRI, counting for 95% for PET-CT and 93.9% for PET-MRI. The last slide are focalized on some clinical cases and experience in our center. This is the first clinical case, a 65-year-old man with some comorbidities. He has a PSA level of 83 nanogram per ml, negative bone scan and doubtful CT scan. He has a clinical staging CT3A and plus because the CT scan show a lymph node metastasis and a gristle score 9. Non-therapy ongoing, therefore fluorocolin PET-MRI was performed for the initial staging of disease. As you can see, the patient demonstrated the presence of a singular lesion with irregular margin in the transitional and posterior left region in the middle and apex portion of the gland, with the evidence of capsular invasion. It was also demonstrated a focal uptake of fluorocolin in the same lesion. However, as you can see, we have also a specific uptake of fluorocolin in the other sites of the prostate gland. But as you can see, we found also a single metastatic lesion in the internal iliac region and the left internal iliac region that demonstrated a diameters of 11 millimeters. But again, as you can see, we found also an increase of the signal in the left superior iliac spine, suggestive for osteomedullary lesion. It was positive to PET colon, but also MRI. Therefore, the patient in this case was upstaged to a stage 3 to the stage 4. The second case is a recurrent prostate cancer, 6-year-old man with a prostate cancer treated with surgery in November 2011, no radiotherapy, intermittent hormonal therapy. He has an increase in PSA level from September 2019 to March 2020 from 0.80 nanogram per ml to 0.56 nanogram per ml. Therefore, fluorocolin PET-MRI was performed for restaging of disease. As you can see, MRI showed the presence of a single node with an increasing contrast enhancement in the arterial phase of 5 mm at the level of vesico-ureteral anastomosis suggested for local recurrence. However, MRI with choline PET was completely negative. But as you can see, we found also a single nodule at the level of the left lateral portion of D5 that was suggesting for the presence of a metastasis, and it was later confirmed also at diffusion weighted imaging that demonstrated the presence of a restriction of the signal and therefore was compatible with the presence of osteomedullary lesion. That was not confirmed by CT that was performed later, just for understanding if it was a osteoblastic lesion or osteomedullary one. Another case, a 71-year-old man undergoing who was treated with radical prostatectomy in 2008, no adjuvant radiotherapy, biochemical recurrence of disease 0.99 milligram per DL in October, and therefore it was submitted to fluorocholine PETCT that did not show any type of significant uptake of fluorocholine in prostatic fossa or lymph node, but just a single uptake in the rib that was compatible with the presence of fracture. Later, after 1 month, again, the patient underwent fluorocholine PET MRI in these cases that demonstrated the presence of perianastomotic recurrence, not only a perianastomotic recurrence at MRI image, but it also demonstrated the presence of a recurrence in a common right iliac lymph node that was not visible at PET-CT choline, but was visible at PET MRI choline performed just 1 month later. Therefore, in conclusion, the ability of PET MRI with the radiolabel PSMA to detect dominant lesion may suggest a further search on prostate fusion biopsy of the suspected area. Nowadays, we have a lot of data about this hot topic, and I think that in the future, this will be a new indication of a PSMA, mainly with PET MRI. Targeting therapies will be directed by PET MRI with the radiolabel PSMA because of its ability both to detect the most aggressive lesion and to assess the extracapsular extension of disease. PET MRI with the radiolabel PSMA or choline could be used for early disease recurrence, mainly in case of a PSA level less than 0.25 nanogram per ml, because it can raise the detection rate to 65% and therefore it could guide to a metastatic directed therapy. Finally, thanks to these advantages, PET MRI can prompt change to the management of prostate cancer patients. Thank you very much for your kind attention. Please do not hesitate to contact me in case of clarification or major information about PET MRI. We can see here my email address. Thank you very much again.
Thank you very much, Dr. Evangelista, for an excellent talk on PET MRI and its role in prostate cancer. Moving on, we will now have Dr. Valentina Ferri join us for a talk on the advances in SPECT-CT for radionuclide therapy. She is trained as a medical physicist in Italy and is currently working at Stanford University as a research data analyst. And this is a topic which is of great importance as individualized medicine is coming more and more into play. And so we will learn about advanced dosimetry.
Hello, everyone. My name is Valentina Ferri, and I am a nuclear medicine physicist at Stanford University Medical Center in California. Welcome to this presentation. I'll be talking about SPECT-guided dosimetry in prognostic applications, and we will see how therapeutic nuclear medicine applications directly benefits from SPECT imaging through the practice of dosimetry. These are the topics I will try to cover. After a quick introduction on what dosimetry is, we will mention the main dosimetry methods. Then I'll talk about the general advanced dosimetry workflow to have an idea where it begins and where it ends. After that, we will discuss the role played by SPECT imaging, and then I'll show you a clinical dosimetry example. Let me start from the definition of dosimetry. In general, the dosimetry is the measure of the dose delivered by the radiation in the interaction with the matter. In particular, as you can see in the equation, the dose is the amount of energy carried by the radiation, which is absorbed by a kilogram of a specified material. The units are joule per kilograms, and this is by definition the gray. In the context of nuclear medicine therapy, dosimetry refers more to the calculation of the absorbed doses delivered to healthy organs and target tissues like tumors before or after the therapeutic injection of a radiopharmaceutical agent. Why the dose is important? Because it is the quantity that allows us to evaluate the safety and efficacy of a therapy. So far, the absorbed dose is in fact considered the most related quantity, either with toxicity and then safety, but also with the response to the therapy to evaluate the dose-response relationship. Let's just keep in mind that from now on, when I talk about dosimetry, I mean internal dosimetry as opposed to external dosimetry, which pertains to radioprotection. In fact, in this context, we are interested in the dose to the regions inside the human body. And thus, we use not dosimeters, but imaging data to assess the radionuclide biodistribution, since we cannot directly measure it, those to organ or tumors with a regular dosimeter. So in order to properly calculate the absorbed dose to a region of interest, we typically need, as you can see here in the bottom, multiple time point imaging to follow the radionuclide distribution in space and in time. What we want ultimately to calculate is how many times those radionuclides decays and how much of the energy they emit gets deposited in the region of interest. This can be done using planar, PET, or SPECT imaging. And the time point, as you can see here, for imaging depend mostly on the radionuclide half-life. Let's see some information about dosimetry. In the context of theranostics, the goal of dosimetry is to personalize the patient's therapy and maximize its efficacy. The idea is to deliver the maximum tolerated activity to the critical healthy organs with the goal of delivering the maximum dose to the tumors. Dosimetry can be calculated either before or after the administration of the pharmaceutical, according to the kind of therapy. For example, one common dosimetry protocol for iodine-131 is to perform dosimetry prior the actual therapy to determine the maximum tolerated activity that gives less than 2 grays to the blood as a surrogate of bone marrow, and less than 120 millicuries whole body retention at 48 hours while giving the maximum dose to the tumor target. While for therapies administered in multiple cycles, as for example, lutetium-177, the dosimetry is performed after the first cycles to determine the activity to be administered in the subsequent cycles. We will see that in an example later. Just a note for context, quantities and nomenclature, as well as most part of the dose limit to critical organs are borrowed, let's say, from external beam radiation therapy, where the practice of dosimetry is well established, and it's a mandatory step for the therapy routine. To underline again the role of dosimetry, we can think about two situations. Without dosimetry, that means fixed number of cycles and fixed radioactivity amount. We must content ourselves with a fixed number of cycles and to the patient, and without any personalization, and without the option to quantify the therapeutic efficacy. The risk of this approach can be undertreatment. The risk, it can be undertreatment. Instead, with dosimetry, we can administer the personalized therapeutical dose to targets without damaging the healthy tissues, the healthy organs, and maximizing the efficacy and preventing undertreatment. An interesting question is how do we bring dosimetry into the clinic? Dosimetry is a complex procedure which requires tools and expertise. And the good news is that in the last, I would say, 2-3 years, there have been many efforts and progresses to facilitate the clinical implementation. So now different commercial and open source solutions are available and improved. You can see here on the right an example of absorbed doses to the kidneys and to a liver tumor for a patient that underwent peptide receptor radionuclide therapy with lutetium-177. That's an example of how the dose distribution looks like after the calculation. I just want to spend 1 minute to clarify which are the two main dosimetry methods. And they're in particular related to SPECT-CT and three-dimensional imaging. Traditionally, dosimetry is performed at the organ level, meaning that is an organ-based approach based on planar imaging, here on the right. Despite being widely used, its accuracy is limited as there is no anatomical information available, and because of region overlapping. These two problems are mainly related to the contouring of the region of interest. This approach provides the average absorbed dose in the target regions. As you can see here on the right, it's a uniform average dose to the kidney, for example. While with the development of two-dimensional SPECT-CT, voxel-based dosimetry has become available. This approach is more advanced and accurate, and the exciting additions are the inclusion of patient-specific anatomical information provided by the CT that allows us to more accurately contour our region of interest, and the transitioning from an average absorbed dose to a dose distribution in the region that accounts for the non-uniform dose distribution within our region of interest. That's the kidney that is represented with voxels, so you can see how the dose is distributed in a non-homogeneous way. This slide is to give you some coordinates on how a typical SPECT-guided dosimetry workflow looks like. and what are the main steps. The workflow starts with image acquisition. As I said, is multiple time point kind of acquisition. And then we have the reconstruction of those images, which is a very, very important step that we will discuss in later. After we reconstruct the images, we perform ROI segmentation, region of interest segmentation, contouring on the fused SPECT-CT images, or sometimes only on the CT, or depends on the region we are interested in. And this has to be done for all the image time point that we have. That's the idea is then to start the dose calculation with the processing of time activity curves that you can see here in the fourth step, which are obtained by from the multiple imaging time points. And there is one time activity curve for each of our region of interest. The more time point we have, the more accurate the curve is. And the accuracy of this curve is very important, as the area under this curve is proportional to the final calculated dose. Last step is with the dose we obtained on this step, we can plan our treatment accordingly. And before showing a clinical example, I will go in the detail of the second step, as the latest step can be handled most of the time by the dosimetry software that offers semi-automated dose calculations with minimal input required from the user. Let me stress the importance of quantitative imaging. The success of the dose calculation depends on how reliable and how accurate the quantification step is, where by quantification, I mean the process of translating our images, which are in units of counts, into units of activity, as becquerel per ml, as we have in PET imaging. In fact, all the parameters as safety, the efficacy, and the response to the treatment depends on how accurate the dose estimates are. For example, with quantitative imaging, we can compare images at different acquired at different times for patients follow-up. Quantification typically requires attention, and as I said, our SPECT-CT devices output images in units of count, which tell us where the radioactivity agent is located. And to obtain becquerel per ml calibrated images and to get then the quantitative information, the medical physicist or the technologist have to run phantoms filled with known activity to obtain the conversion factor. And this conversion factor is applied to the original image to get the quantitative imaging. Also, it's very important to accurately quantify the signal coming from the small regions as tumors. And for that, it is important to apply partial volume effect corrections. As activity in smaller regions, for example, few centimeter diameters, can be underestimated by a factor up to 70%. So these phantom studies are important to get to the quantitative imaging. Good news on this side is that, similar to what we currently have in PET, absolute quantification is for SPECT is becoming available on commercial SPECT-CT devices. And this exciting news is that basically means that those corrections are becoming embedded directly in the reconstruction, and they output images which are ready for either SUV follow-up or for dosimetry. So we can basically skip a demanding step for the implementation of the dosimetry workflow. For example, standard SPECT-CT reconstruction applies all this correction, attenuation, scatter, motion, while quantitative SPECT-CT, in addition to those like standard correction, also implements the conversion factor and the partial volume effect corrections. Let's see now an example of SPECT-CT guided dosimetry in the clinic. Lutathera is, for example, we are taking this example, is a treatment that is normally administered in 4 cycles, 7.4 gigabecquerel or 200 millicuries per cycles. And the goal of dosimetry here, though, is to personalize the treatment and finding the optimal number of cycles and that the patient can get before reaching the dose limit to the critical healthy tissues, like the kidneys, which are organ at risk as they are excreting the administered activity in this kind of therapy. This way, we can give an increased dose to the tumors, and we are able to treat them with more dose than we would do with a fixed amount of cycles. The workflow starts with the therapeutic injection, and then we acquire sequential SPECT-CT post-therapy images within the second cycle of treatment, can be the first or the second cycle. There is a step, as I showed you before, for region of interest segmentation and time activity curve fitting, as well as the dose estimates that are normally performed by the dosimetry software or the dosimetry method of your choice. And finally, the estimate of us assuming that the absorbed dose is constant each cycle, we can plan the treatment accordingly. The dose limits, for example, established by external beam radiation therapy for a patient without risk factor is 23-27 gray to the kidneys, accumulated during the multiple cycles. So once we know how much dose the patient gets in one cycle, we can keep treating the patient till the limit is reached. Another good news is that for under 77 lutetium is now available, a method is available to estimate the absorbed doses from just one single SPECT-CT. One scan at 4 days, 96 hours post-injection. That's a simplified and approximate method, but sometimes, depending on how the nuclear medicine clinic is organized, there may be not inpatient facility, or the patient cannot come back for multiple images. So this approach can be useful as it is less demanding either for the patient and even for the staff. Also, this method can be used together with a full dosimetry approach to repeat the dosimetry at later cycles, increasing the accuracy of the whole treatment planning. And there is here a reference to the paper and to the method. Let's try to clarify better what the cumulative dose limit is and how to interpret the results of our dosimetry calculation. There are several studies that have proven that the therapy efficacy improves if the maximum tolerated dose to kidneys is reached. For example, histogram on the left, you see an example of the number of cycles that can be administered to patients instead of the average 4 cycles. The study considered 2 thresholds, 27 and 40 grays to the kidneys. And the first group received a median number of 5 cycles. The second group received a median number of cycles of 7. Overall, 73% of the patients were able to receive more than 4 cycles. You can see here that just a small percentage of patients received the 4 cycles from like the prescription. Some of them also received less, and but most of them received more than 4. These limits you see is 27, 40, may be confusing, but there is currently no clear cut on these dose limits, as they are currently borrowed from external beam radiation therapy, as I mentioned in the beginning, and therefore we need more studies to clearly define these limits, specifically for internal radiotherapy. On the other study on the right shows progression-free survival and overall survival curves in 2 cases. One, when a kidney dosimetry-based approach is used versus a fixed number of cycle approach. In the first case, where progression-free survival and overall survival improve significantly, when the patient reached the threshold to the kidneys is this blue curve, not reached is the red one. Same for the overall survival. And these are only 2 of the many studies available on the topic. It's worth mentioning that the Lutathera fixed approach is a way to have the therapy approved and available on a larger scale. So that's positive that we have that. But traditionally, these therapies were entirely based on dosimetry, and many data has been collected over time. Let me go to the conclusion. I like to think about SPECT-CT guided dosimetry as a powerful tool to unravel information that are useful and often overlooked, that can make a difference in the treatment efficacy. SPECT-CT guided dosimetry not only also enable us to plan the treatment for the single patient, but also helps building a strong basis to advance the diagnostic field, where the main challenge now is to deepen our understanding of the biological effects of radiation on tumor cells. Thank you very much for your attention. Please reach out to me if you have any further questions.
Thank you, Valentina, for an excellent talk. Now, we have about 10 minutes, and I think it's an excellent time for us to take questions from the audience. We've got our panelists here. So I think we'll start with Dr. Gnanasegaran. I think there are lots of things about gallium dotatate and gallium DOTA-NOC and their diagnostic performance. I think that question comes up on a clinical level routinely. So if you could just give your opinion on what has your experience been with regards to this?
Well, in terms of imaging for neuroendocrine tumors, gallium-based tracer is the diagnostic tracer of choice, because often people ask questions in terms of whether to use a SPECT tracer or a PET tracer, because the availability of gallium generator is not easily accessible because it is expensive. As only few centers will have accessibility to gallium-based generator. But the question is whether you are looking in terms for just diagnosis or for treatment. In terms of diagnosis, by using a gallium-based tracer, you have a chance of detecting at least more than 30% of extra lesions in compared to SPECT-based tracers. But in terms of selecting patients to treatment, you can use either of the tracer, but if you don't have a gallium-based generator, you can still use a spec-based tracers, either the technetium labeled is becoming more easy to use now compared to the indium-based ones and availability. So the choice depends on what you have. But given me the choice, I feel gallium-based tracer are excellent.
Excellent. But in the gallium tracers, based on their receptor affinity, what would you bind them with? Would you prefer DOTA knock?
We use gallium dotatate, but again, if it is part of some trial, we use gallium DOTA knock. So in general, I don't think there's that much of a difference. As long as you use a gallium-based tracer, you get a better outlook when compared to the spec tracer. So we should not go too deep into knock or talk or something like that. But in general, more or less, it is fine.
Okay, great. And I actually appreciate, I think I have all of you up very late or very early in the morning. So everyone's looking nice and fresh. Excellent. I'll send this next question to Dr. Humayun. Dr. Humayun, setting up a gallium-68 dotatate facility here at Shaukat Khanum, you were integrally involved in it. What challenges did you face?
You're muted.
Oh, yeah. No, we can't hear you. No, can't hear you.
In the meantime, may I have a question to Dr. Gopinath, just for understanding if he has any type of experience about the treatment of patients with medulloblastoma, or also something of like with the lutetium-177 dotatate?
No, we don't have, but previously, actually, I personally don't have experience, but in our department in the past, Professor John Buscombe used to, it's not medulloblastoma, he used to treat glioblastomas with an intra-arterial sort of PRRT. So personally, I have no experience in treating other than the JEPNETs, adult JEPNETs.
Thank you very much, because it is a really important topic, because as we know, unfortunately, we have not a lot of type of treatment for the treatment of patients with brain disease.
Yeah.
Therefore, we have also to think that in the future, probably our therapy could be important also in this topic. Thank you very much for your
so people have tried in the past, but within the UK, it's based on funding and other things. Therefore, we are not. Thank you.
Thank you.
I think Dr. Humayun is having some issues with the mic while he sorts that out. Do you have a gallium setup, Dr. Evangelist, at your center? Do you
gallium with DOTATOC or with PSMA? With DOTATOC, not yet, because we have some problem, unfortunately, as also UK with the founding of for gallium DOTATOC, but we hope to start in the next year, because now we have received some money for this, I hope, investment.
Sure, excellent. Dr. Humayun, are you online?
Yeah, can you hear me now?
Yes, excellent.
Okay, so these old headphones work better than the new ones. Right, well, as far as the challenges regarding the setting up of gallium-68 service are concerned, now I have got experience. In Pakistan, it was difficult. In UK, it's even more difficult. Now I realize that in Pakistan, it's more of a central thing. Of course, cost is an issue. And now, because the demand is there, the clinical impact is well established. Clinicians acknowledge it, nuclear physicians and the service have reached out. So now I think the missing bit was how to cover the cost and justify the cost. And I feel, it's just personal feeling, having traveled between two countries for this procedure, for establishing it, I think somehow the pandemic has helped it. Now we are in a better position to tell the financiers or the deciding bodies that it's important to have the facilities for diagnostics as well as radionuclide therapy closer to the patients, rather than Dr. Gopi knows when we were trained in UK like 15 years ago, everybody used to travel to Royal Free for radionuclide therapy from all across England. and even from as far as Scotland. Now, there are more centers around this country as well, and similarly in the rest of the world. And the pandemic has emphasized that it's important to have these facilities closer to home, diagnostic as well as therapeutic, and across the globe. I just feel that whether the supplies of these radionuclides, will that be possible at that global scale? Now with US in the game and the kind of consumption they can have, how many generators can be produced and supplied across the globe. So that I think is a challenge which will be taken up by larger bodies. Dr. Gopi is now part of the World Federation. We just hope that there are people at that level looking at these things, because radionuclide therapy is becoming the fourth pillar of oncology care. It's quite evident with PSMA therapy and with newer things coming up like tritium labeling FAPI. And so we'll be having more options very soon. It's just that, see, we don't get into a supply and demand situation sometimes. So thank you.
Thank you. Thank you. Now, if I switch gears towards dosimetric therapy planning, a great talk, Valentina. Now, if there's some questions actually Dr. Gopi has posed for you.
Yes.
I don't know if you have access to them. Should I read them out?
Yeah. Which one? So there is one about a dosimetry protocol.
Yeah. And then there's planning, which translates to, does it translate to decreased toxicity?
Yeah.
And good tumor response?
First, user-friendly dosimetry protocol. So basically, I think, so there are a few protocols there. It's very important to, really depends on the equipment, depends on the software that one's decide to use. So there are a few steps that there is no current like standard protocol starting from imaging to dose calculation, but there are there are tools that are better than others to help with that. So there is some, there is no standard protocol, but as I said, there are there are options now in available for set up a clinical friendly dosimetry protocol from imaging to dose calculation. We can discuss it more in detail, but I would say yes. And about therapy planning translate to decreased toxicity and good tumor response rate. So there is so the evidence that has been collected over like almost 20 years now, even more, of target therapies that ultimately produce also for example, the Lutathera, like lutetium-177 based therapy. And there are studies and there is evidence. Is not probably there is still discussion on this going on, but there is evidence, there are papers, there are and there is for sure more work to do to collect more data to gather a stronger evidence. But also I can provide some paper, I can provide some resource to some reference by even my email to look into that more deeply.
And then SPECT versus PET-based dosimetry, which one do you think is better?
I think that there is no, I mean, this is, the real question is what kind of imaging, how do you image your isotope? So it really depends on which kind of emission the isotope you want to calculate dosimetry for, where you can image it, right? So lutetium, for example, you can image only on SPECT. So that's the dosimetry for lutetium is based on SPECT, while dosimetry for PET in PET is mostly related to preclinical studies, where when you want to evaluate like a new diagnostic agent, so then you perform dosimetry on PET for a different purpose. Like for SPECT, the SPECT-based dosimetry is mostly for therapeutic, for isotopes that are for therapeutic purposes. So it's mostly, doesn't really, PET for sure has a better resolution. So quantification is something that is more established. And so, but they are not really comparable at this point.
Okay.
They
Great,
serve
great.
two different purposes.
Okay. Then we have another one from Dr. Hamayu, I think. It says, are medical imaging physicists taking up the opportunity of a key role in radioligand therapy? Is it similar to that of physicists in radiation oncology?
Yeah, I mean, yes. So the goal of the role of dosimetry, as I said, is like planning the therapy. So the physicist is the person that would perform dosimetry for in this case. So I would say yes, that's an equivalent role, yeah, to radiation oncology. Yes.
Okay, great, great. Then we have one more question. Lots of questions for you. Are you using internal dosimetry for PRRT routinely? If yes, which software do you use?
So routinely, not really, not on all patients. So currently we are doing it only on some cases that are special, with particular concerns. So we are concerned that the dose may be too much to the kidneys, or there are other concerns. I'm using MIM software, but I've been using many different software in different, settings. And yeah, it's that's what I'm using now.
Okay, great,
right now.
great. And in terms of PET-MR, Dr. Evangelista, how busy is your center or other centers? As you know, it's like you said, 100 odd PET-MRs around the world, actually. So in terms of workload, these centers, what volume are you seeing per week, perhaps, or per month?
Okay, usually we have different type of indication for PET-MRI. It means that we cover both oncological and non-oncological indication. Therefore, the daily schedule is quite different the day from another day, because we have also the different in terms of radio tracers. Usually we can cover not more than 6-7 examination per day in case of full body acquisition protocol. And we can reach also 12 per day in case of PET-MRI in the brain protocol. And when we perform the entire day from the 8 in morning to 8 in the evening, therefore in 12 hours, so we cannot make a lot of PET-MRI acquisition because it is very long. For example, for some oncological indication like for gynecological, also prostatic cancer, the acquisition time is more than 1 hour. Therefore, the schedule is not so big, but is very, very limited. Yeah.
Sure, sure.
And some centers that has a similar experience like ours.
Great. And I think the same experience for Dr. Gopi as well, I'm sure.
We don't have PET-MR, but the University College London Hospital does have PET-MRI.
Oh.
So they often do quite a lot of neuroendocrine and prostate cancer patients. Whenever the PET-CT camera is busy, they take some patients from PET-CT to PET-MR and try to do few. But again, it's a long way, I think. So there's not a real clear definition where you're going to use PET-MR properly. Worldwide, they may have 100 scanners, but there is no clear document anywhere in terms of literature. Is very limited to say where are the conditions where you can use it and whether it's got any patient impact or something like that. But still, I think, though it's been there for the last 10 years, still it's a long way to go.
And I think, it's just, I feel that the discussion about PET-MR is helping proliferation of PET-CT. In the end, people decide, okay, at least if you're talking about PET-MR, at least this center or that particular area should have a PET-CT. As regards this dosimetry, Valentina, it's a very important talk. That's why we wanted to be part of this program. I hope that this medical imaging physicists actually get more and more into it. It becomes more of a natural thing, part of radioligand therapy, and but at no stage it becomes an impediment for the growth of radionuclide therapy. Because we have been in discussions where they said, well, dosimetry is essential. It's important, it's essential, but it should not lead to, because there's also a discussion about in the end, clinical, practical, empirical protocols have to be there for a success of a therapy. If we start tweeting it to every patient, every kidney, every liver, we'll end up with a research tool which will just remain in research. So I just hope that that was a part of discussion of the vision trial as well, that there are reasons it was kept at empiric doses, at empiric cycles, and that's essentially how it works. And with dosimetry tools available more readily, more effectively used, all centers will have their baseline dosimetry data available, and of course globally, universally, which is used and applied, so the therapy proliferates at the speed of the malignancy that we're dealing with.
But one thing is we should not forget is, in terms of dosimetry comes an additional cost, right?
Yeah.
And often the funding is only for the treatment. In fact, even if you're doing a post-therapy lutetium scan, that particular scan is not funded. It is only the funding is for the treatment. So therefore, unless we have a logistic protocol, because I've been hearing about dosimetry for the last 15, 20 years from the day I started, which I asked the same question, like PET versus SPECT dosimetry. I asked the same question 15 years ago, and still we are evolving. So it comes with a cost. And the second thing is we don't have training facilities. So we need to have a special training to people so that it becomes more viable and people get used to it. Otherwise, it's going to be challenging.
Yeah.
If I can say something about the cost, so in the US recently, there are 3 codes available for billing, for imaging, for post-therapy imaging, for dosimetry imaging, for dosimetry, and also for the time of the dosimetry calculation. So we still have to try to bill and see if they come back. But it's just a step forward that just a couple of years ago was not there. So something is moving.
That's excellent, because at the end of the day, it does translate to economics, especially in the US, and I'm sure in the UK as well.
Yeah,
certainly.
And you see, like in cardiology, we have got these nomograms databases, and DEXA, we've got databases. That sort of solution has to come up with the equipment, with the machines for therapies. Of course, there's always a requirement that every center and country and population should have their own normal cardiology database to compare with. But in the end, that's not possible. Every country doesn't have a standard DEXA database to compare with. So dosimetry database has to be global. There's enough population spread across the globe in Europe and especially in America, from where a standard database can be created. And variations will be predictable because this as Gopi has mentioned, it should not become an impediment cost-wise, logistic-wise. And because dosimetry was an issue, therapy this time lagged behind. I don't think we have that opportunity in this day and age.
Yeah, great.
Great. So I'd like to thank you all for joining us in this excellent session, and the audience, participation from the audience, our panelists. Thank you so much. And I appreciate the effort from our symposium committee as well. It's been a wonderful session. Thank you so much. I will let you get back to your morning or late night as it is.
Thank you very much.
Thank you very much.
Excellent. Thanks.
Thank you all.
Thank you all. Thank you very much. Bye.
Bye.